Yeah, good evening, everybody. I would like to welcome you in this very hot weather. I hope you enjoy yourself in the air condition or the fans or whatever. Actually, today there's some noise. Actually, today is the fifth wave of the cardio risk activity during this year, 2021. Today, I would like to ask to thank Amgen company for their support for our educational activity. I would like also to thank the great faculty with me today, Dr. عاطف البحري, Dr. Mohammed Selim, Dr. Ahmed Shawqi, Dr. Tamer, Ahmed Al-Qirsh, Dr. Walid Abd, Dr. Said Farag, Dr. Hani Ragi, a great faculty really, and I think it will be a great discussion also. Today, first session, I will leave the stage to the moderator of first session, Mohammed Selim. Unfortunately, Hazem Khamis is not with us, so we have Mohammed Selim and Ahmed Al-Qirsh from the panelists, from the moderator of the first session. They will have the other faculty as panelists. Dr. Selim, Fadda. Unmute the mic.
Good evening, Dr. Ashraf. Dr. Ashraf.
Dr. Ahmed, here. It's always our pleasure, Dr. Ashraf, to be with you and with the great faculty and colleagues in the IAVA, and we enjoyed these scientific discussions. And I think today we have a very interesting new wave of our activity, and we will start by a very important topic by Professor Atif Al-Bahri. He will give us a very interesting talk about the biology of PCSK9 inhibitors.
Thank you very much, Professor Selim, for your introduction. Only the study of the science of PCSK9 was very important since 18 years. And by studying this biology, we can understand why it's very important in the management of atherosclerotic cardiovascular disease. If you look here, this is cholesterol. Cholesterol is essential to life. Cell membrane component, steroid hormone precursor, vitamin D precursor, and bile acid precursor, but cholesterol is a key component of atherosclerotic plaques. Human plasma LDL particles here containing 50% by weight of cholesterol. So it is a principal transport of cholesterol between sites of absorption, synthesis, utilization, and storage. And we knew that LDL cholesterol is a cause for atherosclerotic cardiovascular disease by inherited disorders of lipid metabolism and by etiologic studies for linear association between LDL cholesterol and atherosclerotic cardiovascular disease, by IVAS studies showing the progression of plaque, which is arrested at LDL cholesterol less than 1.8 millimole. The mechanistic studies shows that LDL is directly implicated in the initiation and progression of atherosclerotic cardiovascular disease. The randomized controlled trials showing reducing LDL cholesterol with a statin, for example, reduce the atherosclerotic cardiovascular disease. And randomization studies show association between LDL cholesterol and risk of atherosclerotic cardiovascular disease independent of this LDL lowering. LDL has both a cause and cumulative effect on coronary heart disease. As we see, this is the pharmacologically lowering of LDL cholesterol, lower the proportional risk reduction, and genetically lower LDL cholesterol. LDL cholesterol here also have a linear effect on the proportion of risk reduction. LDL cholesterol and coronary heart disease risk in diabetes, for example, there is a much increase in coronary risk by 1.57-fold with each 1 millimole increase in LDL cholesterol. Our story today is the biology of PCK9. Which factors are central to the physiological control of circulating LDL levels? We have two. Number one, LDL receptor, and PCK9, which is called the protein convertase substituting 9. The science of PCK9 started its history in 1974. They discover LDL receptor, and they have a prize of Nobel. And then in 2003, it was a discovery of the PCK9 by the gain of function mutations in some families causes familial hypercholesterolemia. And in 2005, the PCK9 loss of function mutation associated with reduced cardiovascular risk was discovered in the ARC studies. And then the ASO-mediated PCK9 inhibition in mice in 2007. And then the development of monoclonal antibodies for PCK9 inhibition reduces LDL cholesterol in the primates was in 2009. In 2009, we started to speak about PCK9 in the cardiolipid, which was held in Stella de Mari in Sokhna, and it was very astonishing. And in 2012, there is a phase 1 clinical trials for monoclonal antibodies, PCK9 inhibitors, and in 2017, the PCK9 inhibitor therapy reduces the cardiovascular events by 2 major studies. We go back again to the biology of PCK9. Both PCK9 and LDL receptors expression are turned on by the SRPP2, which is the steroid regulatory element binding protein 2, which regulate the synthesis and cellular uptake of 2 major building blocks of cell membranes called steroid and fatty acids. So both are going all together. The LDL receptors and PCK9 after apparatus. And we find some LDL receptors are going again inside cells and causing recycling after taking the LDL cholesterol. But the PCK9 here, we can be attached to the LDL receptor to go to disintegrate both of them in the lysosome. The cellular LDL receptor, as we see here, this is the domains, visual binding, and the epidermal gross, all linked sugars, membrane spanning cytoplasmic. This is the lesion binding, and the life cycle LDL receptors, as we see here, we can see each LDL receptor recycles about 100 times over its 24-hour life cycle. And this is very astonishing too. LDL receptor synthesis occurring in the endoplasmic reticulum, and then it goes to the Golgi apparatus, to the surface of the membrane of the liver, and then it takes the LDL cholesterol by coated bit and goes inside the cells again on a coated vesicle, and is going to the endosome and lysosome, and then recycle again to the recycled vesicle and going to the surface again. This is the normal life cycle of the LDL receptor. The PCK9 undergoes intracellular autocatalytic cleavage to take up its activity confirmation for LDL receptor binding. The liver is the principal source of PCK9 production, although there are many sites where PCK9 can be manufactured in the brain, in the kidney, in the pancreas, and everywhere. But the liver is the principal source of PCK9 production. We can see here the binding of PCK9 to the LDL receptors occurring at this site, the EGF-like repeats and the catalytic domain. The PCK9 reduces the LDL receptor recycle, lowering LDL receptor activity. As we see, LDL receptor and PCK9 synthesis occurring in the same place on the plasmic reticulum, and then to the Golgi apparatus, and going all together to the surface. And PCK9 is attached to the LDL receptor and the LDL cholesterol particle by a coated bit, and then go by coated and in the endosome, lysosome, which is disintegrated. And if you look for the recycling vesicle here, it is empty. No more LDL receptor. Very important slide here that show that the stochastic interaction between the LDL receptor and the LDL bound PCSK9 portion. We find here that about 1 in every 500 LDL particles carries PCSK9, because the PCSK9 is not only attached to the LDL receptor, but it binds to the LDL particle. So 1 in every 500 LDL particles carries a PCSK9, as we see in this slide, which is very important. And the stochastic interaction, as we see here, this is we have no astonishing that because PCSK9 is found on 1 in every 5 or 100 LDL particle, so one can envision a scenario where 1 in every 500 encounters an LDL receptor binds to an LDL particle harboring a molecule of PCSK9. And such stochastic interaction will then lead to the degradation of the receptor rather to its recycling, explaining at least in part why LDL receptor recycles hundreds of times, as I told you before. This slide also is a very important slide. This slide shows that the PCSK9 has two types. Is found in the plasma, primarily in two monomeric forms. An active form having a full-length plasma protein, and an inactive form which is a shorter fragment which cleaved by the protease furin. The active form is found predominantly on the LDL and lipoprotein A, as we see in these slides, in addition to the LDL receptor, to protect the PCSK9 from cleavage by the furin. The inactive form is degraded by the furin cleavage, is not found in association with any of the apolipoprotein, and has a low affinity to the LDL receptor with limited ability or inability to degrade LDL receptor. So the forms of this PCSK9 is very important to differentiate between them and to know a new point. PCSK9 is not only attached to the LDL receptor, but it goes to harbor inside the LDL and the lipoprotein A. This slide from Giuseppe Danilo Nurata shows the biology of the PCSK9. As we see here, this is a free intact PCSK9, which is not degraded by the furin cleavage, and it is attached to the LDL particle, and then and then it goes again to the surface to be rested or docking on the LDL receptor to go inside the liver cells to be disintegrated. The absence of PCSK9 leads to marked increase in LDL receptor. In the beginning, they showed that PCSK9 knockout mice increase hepatic LDL receptor levels, and PCSK9 decreases the number of cellular LDL receptors, so LDL cholesterol is increased as we see. A PCSK9 gain of function mutation determines autosomal dominant hypercholesterolemia, affecting family members like total cholesterol in 90th percentile, and tendon xanthomas, premature coronary heart disease, early myocardial infarction, and stroke. And this is a very important paper published in 2003 by Marianne Abifadel in France. And Marianne Abifadel discovered the gain of function. The PCSK9 genetics here also can see LDL levels and cardiovascular disease, rare gain of function mutations, high LDL cholesterol, premature cardiovascular disease, but the common is loss of function mutations and lower LDL cholesterol, lower incidence of cardiovascular disease, which resembles about the 38% decrease or 28% reduction. The loss of function of PCSK9 mutation lifelong have low LDL and low cardiovascular risk, and this is from the ARIC study by Cohen in the States, and showed that the 88% reduction in risk of coronary heart disease events during 15 years of follow-up in patients having no PCSK9, as we see here, and they have low LDL cholesterol, as we see. this loss of function. Recently, the effects of the main natural mutations of the PCSK9 domains on cholesterol homeostasis phenotypes and their impact on the cardiovascular risk, as we see, this is loss of function, and this is the domains of mutations. Now the new is the numbers of them, and if loss of function causing decrease of PCSK9 activity, decreasing affinity for LDL receptor, decreasing LDL receptor degradation, decreasing LDL plasma level, and decreasing cardiovascular risk. But the gain of function increasing the PCSK9 activity and increasing the affinity of LDL receptor, increasing LDL receptor degradation, and increase LDL cholesterol plasma level, leading to increased cardiovascular risk. Another story for the PCSK9 shown here and published recently in 2021 in the International Journal of Molecular Science. A very beautiful slide showed that serum PCSK9 levels were independently correlated with a high on treatment platelet activity and a higher incidence of atherosclerotic outcomes in patients with acute coronary syndrome. This is the PCSK9 acting on the endothelial cells and causing increased release of molecules, interleukins, the tumor necrosis factor, 6L2 and MPC1, and going to the macrophages, stimulating the SRA, the CD36, LOX1 expression and oxidized LDL cholesterol, leading to increasing the oxidized LDL uptake and the production of the NLRP3 inflammasome activation, which lead to inflammation at the atherosclerotic site, leading to the development and the progression of atherosclerosis and the platelet activity, leading to atherosclerosis. So PCSK9, therefore, is very important in patients with acute coronary syndrome to give it very early. And we will hear here from Professor Hani Bragi why we should prescribe not only for the reduction of LDL cholesterol, but I think here in this paper is very important that the molecular pathway implicated of PCSK9 on the platelet activity. So PCSK9 deficiency is not deleterious to health. Individuals who completely lack PCSK9 and have very low LDL levels, approximately 15 milligram per deciliter, and are healthy, and therefore inhibition of PCSK9 represents a valid pharmacologic approach to management of hypercholesterolemia and cardiovascular disease prevention. The drug targets to lower the LDL cholesterol service now, PCSK9 inhibitors, and also the other new PCSK9, which prevents the synthesis inside the cells, now is starting to be a new era to prevent the LDL cholesterol therapy. We should have some notes here that the mechanism of statin-mediated upregulation of the LDLR gene via the SRPP, we find that statin stimulates the SRPP and causes expression of LDL receptor. But misfortunately, statin also have an upregulation. When we give statin, there is upregulation of the LDL receptor and the PCSK9 altogether genes via the SRPP2. Statins and PCSK9 and LDL, the increasing activity mediated by statins is attenuated by the upregulation of the PCSK9 production. Therefore, the targeting of PCSK9 can potentially increase LDL receptor activity on the surface of liver cells, with subsequent decrease in circulating LDL cholesterol levels. And this is, we can see it when we add PCSK9 inhibitors on high maximum tolerated dose of statins, a high intensity statin. We find that there is much improvement for those patients. My key message: genetics provide irrefutable evidence that PCSK9 plays a key role in regulating LDL receptor activity and in turn circulating LDL levels. Genetically determined low LDL cholesterol levels from birth protect against premature atherosclerotic cardiovascular disease. Genetically determined absence of PCSK9 is not deleterious to health. Considered together, these data strongly support the concept that PCSK9 constitutes a privileged therapeutic target for reduction in LDL cholesterol levels in subjects at elevated atherosclerotic cardiovascular disease. So the PCSK9 science and its translation to novel treatments will transform the prognosis of millions of people worldwide with atherosclerotic cardiovascular disease to a better life. And thanks for your kind attention.
Thank you, Atif. Actually, elegant presentation. I enjoyed it, and I think مش يعني صعب قوي ان حد يحضر المحاضره بالساينس ده، ورغم انها صعوبه بالغه في بعض الحاجات، انما مفهومه جدا وفيها كلير مسج. السؤال دلوقتي واضح ان الPCSK9 ده is something which is deleterious, which is has bad effects in our body. Because when it is present in high level, that means that our LDL receptor is not working well. So one can ask himself why it is created originally in our body. What was its functions? I think it was preliminary present to protect the mankind against starvation, because in the old day, when the guy is starved, he need his cholesterol to be kept in blood. So with PCSK9, in activation of the receptors, you keep the cholesterol high. But when we changed our lifestyle, when we eat every day meat, bread, and mayonnaise, and so it become deleterious in our body. Do you read anything about this in your search?
Yes.
Biology of PCSK9?
Yes, of course, Dr. Ashraf, PCSK9 is a big science, and our God created it in our bodies because of many reasons. It is very important for the brain, for during the maturation of the babies inside their mothers. Important for the neurocognitive function. It is very important for the neural apoptosis. It acts on the pancreas also to protect the beta cells. There are also has an action on the kidney also, and therefore, but the benefits here is if it gains its full function, and the mutations happened here to have more increase of the PCSK9 in the circulating plasma or the inside the tissues, it turns on a catastrophe to be very deleterious to health, as we see, because it acts on the macrophages, on the endothelial cells, and on the platelets, and it is attached to the LDL particles, the lipoprotein particles, but not the very low density lipoprotein, and not to the chylomicron. Therefore, of course, we can weigh the beneficial effect of inhibiting this PCSK9 and its beneficial effect, which when they measured all the people working in the labs and discovering this PCSK9, they stated that its deleterious effect is more than its beneficial effect.
اوكي احمد القرش، اعتقد دكتور احمد
Thanks, Professor Dr. Atif Bahri, for this elegant, tough subject. We'll move to the second speaker.
محمد سليم عايز يقول حاجة. محمد سليم
I have a question, Dr. Ahmed. Thank you, Dr. Atif. It's really very interesting presentation. And it's a new information for me that there is an interplay between the PCSK9 and the platelets, which is a very important piece of information that could, we can say that by inhibiting the PCSK9, we may have a pleiotropic effect for inhibiting also the platelets.
Yes.
What do you think about this?
And they make two studies, and they find that the patients having acute coronary syndrome have a peak of PCSK9 in the plasma, and therefore when they notice they start to make some studies about it on the platelets. Because it's very important to know it is not only the LDL cholesterol or not only the LDL receptor, it has another action on the platelet, and therefore the European Society of Cardiology, the guidelines we will see in the next lectures, in cases of patients have acute syndrome and are on high statins and stomide, they should be given the PCSK9 monoclonal antibodies in the hospital immediately. This is not the prolonged action of the PCSK9 to lower LDL. I think this is for the acute effect of the PCSK9 on the platelets.
دكتور عاطف شكرا.
Thank you, Dr. عاطف.
دكتور عاطف there is any relation between.
أنا مش سامعك يا دكتور تامر، مش سامعك خالص.
دكتور عاطف شكرا على محاضرتك الرائعة. وبسأل حضرتك is there is any relation between PCSK9 and diabetes?
There is yes. There is a good question. Yes, the PCSK9 inside the pancreatic cells prevent the occurrence of the metabolic syndrome. Misfortunately, it is very beneficial. And but for the studies that we see it from the Fourier study, for other studies using the monoclonal antibodies, there was no increased incidence of diabetes in such patients, and therefore it passed over. And they stated that is reduction of PCSK9 inside the pancreas have no effect on the diabetes incidence.
Okay. شكرا دكتور.
دكتور عاطف.
دكتور احمد. الصوت يا جماعه في حاجه غلط.
هرجع لنفس السؤال بتاع الدكتور سليم. الريليشن بين البيسكيناينز والبليتلتس، وحضرتك اتكلمت على الاكيوت كريش سندروم ان بيحصل بيكينج في البيسكيناين during acute crash syndrome.
هو في ستادي مش سامعك يا دكتور احمد.
في ستادي
مش سامعك يا دكتور احمد.
اتفضل يا بيه.
انا مش سامعك.
during acute crash syndromes. كده سامعني يا دكتور عاطف؟
ايوه
دكتور عاطف.
انت ميوتد يا دكتور احمد، او اكتب السؤال، يعني اكتب السؤال على الشات كده، يعني اكتب السؤال.
حضرتك سامعني كده؟
ايوه
حضرتك سامعني كده يا دكتور عاطف؟
ايوه احسن.
حضرتك كنت بتتكلم على الكورليشن بين البيسكيناين بيكينج.
الصوت قطع تاني يا احمد. ايوه
البيسكيناين بيكينج اكيوت during acute crash syndrome.
معاك
في برزنتيشن يا عاطف افتكر يا دكتور احمد على الاكيوت كروش سندروم والبيسكيناين كامله ان شاء الله.
هاني هيتكلم عليها.
اوكي ماشي.
هاني هيتكلم عليها.
I think we can move Ahmed to the next presentation. by Dr. Professor
presentation وليد عبده. بروفيسور وليد عبده. دكتور وليد.
شكرا.
دكتور وليد هيكلمنا عن الجايد لاينز بقى في PCSK9 بعد ما فهمنا من الدكتور عاطف. We take a journey through the biology of PCSK9. What about using of PCSK9 inhibitors in the guidelines?
بسم الله الرحمن الرحيم. Thank you, Dr. Ahmed, for the nice introduction. Thank you, Dr. Atif, for the great presentation as usual. Thank you, Dr. Ashraf, and all the IAFA board for this continuous scientific meetings and activities. My talk is about the PCSK9 inhibitors in the guidelines, or actually the journey of the PCSK9 inhibitors till it reached its current position in the guidelines. There is no doubt that the LDL level is directly correlated with the risk for coronary heart disease. And the higher the LDL cholesterol level, the higher the risk for coronary heart disease. And we have data from about 26 randomized trials on more than 170,000 patients showed that for each 1 millimole per liter reduction in the LDL cholesterol, irrespective of its baseline level, this was associated with 22% reduction in the cardiovascular events and about 10% reduction in the mortality. And over about 30 years of treating the LDL cholesterol, it seems that the target of the LDL is going lower and lower over time. And the lower is better is not enough now, and now the lowest is the best. In spite of that, we have real-world data from international analysis of 17 guidelines and 42 observational studies showed that many of high-risk patients and very high-risk patients do not achieve, unfortunately, the LDL cholesterol target with statin. And this was applied almost to all countries worldwide, in Arabian countries, Asian countries, European countries, and USA. Even after addition of ezetimibe, also still patients with atherosclerotic cardiovascular disease with high risk and very high risk category do not achieve the LDL cholesterol goal, even if the baseline of the LDL was less than 130 or more than 130 milligram per deciliter. And you have data from the CEPHEUS study in Egypt showed that just about 11% in the very high risk patients and just about 34% in the high risk patients achieving the LDL cholesterol goals, and the rest of these all high risk category do not achieve the target LDL cholesterol level. So although the deaths due to heart disease declined dramatically over the past 2 decades, still the number of deaths remains high and the residual risk remains. And in the placebo-controlled statin trials showed that the residual risk is still there, even after reduction of the LDL cholesterol by about 30 or 35% in most of the trials, still the residual risk exists. And even on patients taking high-dose statin therapy, and if the LDL in some trials reaches less than 70 milligram per deciliter, still the residual risk for major cardiovascular disease event exists. And this can be explained partially, as Dr. Atif just said, by what is called the statin escape phenomenon. That when we give statin, the intrahepatic cholesterol pool is decreased, and this leads to activation of this sterol regulatory element binding protein 2, which increase the LDL receptor expression, and at the same time it increases the PCSK9 gene expression, which increase the PCSK9 level and lead to degradation of the LDL receptors. So we have unmet clinical need. Despite best evidence-based treatment, high risk and very high risk patients continue to experience cardiovascular disease events. Failure to attain guideline recommended LDL cholesterol goals is an important component of this residual cardiovascular risk. So additional LDL cholesterol lowering options are needed to address this unmet clinical need. And we have data from population studies from the Copenhagen City Heart Study, Copenhagen General Population Study, Copenhagen Ischemic Heart Disease Study, and also atherosclerosis risk community study, that patients with loss of function mutation in the PCSK9 or total lack of PCSK9 have naturally low levels of LDL cholesterol and reduced coronary heart disease. And this lack of PCSK9 was safe and was not associated with other detectable abnormalities. As we see here, in the patients with a loss of function mutation, PCSK9, the increased number of the LDL receptor on the hepatocyte surface lead to decrease in the circulating LDL cholesterol. So by inhibition of this PCSK9 by using monoclonal antibodies, we can increase the LDL recycling rate and increase the number of surface LDL receptors that decrease the circulating LDL level. So this is the timeline development of the PCSK9 inhibitors. As Dr. Atif said, it was first described in 2003, and through many years with and the PCSK9 inhibitors underwent many trials on humans and animals, and finally in 2015, Food and Drug Administration approval for PCSK9 inhibitors, evolocumab and alirocumab, was approved to be used in the in USA. And in 2017 and 2018, we got finally the results of major cardiovascular endpoint studies. And till 2015, we had about 17 studies on PCSK9 inhibitors on more than 10,000 patients, and all these studies approved the efficacy of adding PCSK9 inhibitors in the treatment for dyslipidemia, either alone or in combination with statin and ezetimibe. PCSK9 inhibitors plus high-intensity statin can lead to average LDL reduction by 75%. PCSK9 inhibitors plus high-intensity statin plus ezetimibe can lead to average LDL reduction by about 85%. And we have the two major clinical trials that changed the guidelines. The Fourier study studied the evolocumab in patients with stable cardiovascular disease, and the Odyssey outcome study studied the alirocumab in patients after acute coronary syndrome. In the Fourier study, more than 27,000 high-risk stable patients with established cardiovascular disease. Already, they were on high or moderate intensity statin therapy plus or minus ezetimibe with LDL level more than 70 milligram per deciliter or non-HDL more than 100 milligram per deciliter, were randomized either to evolocumab or placebo, and the patients were followed up for more than 2 years. Primary endpoint was the cardiovascular death, MI, stroke, unstable angina, coronary revascularization, and secondary endpoint was the composite of cardiovascular death, MI, and stroke. And it was shown that in the arm of evolocumab, there was a 59% reduction in the circulating LDL cholesterol compared to the placebo group, with absolute reduction of 56 milligram per deciliter, and this was translated into significant reduction in the primary endpoints, with a significant 15% reduction in the cardiovascular death, MI, stroke, unstable angina, or coronary revascularization, and also significant 20% reduction in the composite of cardiovascular death, MI, and stroke. In the Odyssey outcome trial, post-acute coronary syndrome patients, more than 18,000 patients post-acute coronary syndrome were on high-intensity or maximum tolerated dose of statin, atorvastatin, or rosuvastatin, were randomized either to alirocumab or placebo, and the patients were followed up for about 3 years. The primary endpoint were the cardiovascular death, non-fatal MI, ischemic stroke, or unstable angina requiring hospitalization. And it was shown that in the alirocumab group, there was about 55% reduction in the mean LDL cholesterol compared to the placebo, and this was translated into a significant 15% reduction in the primary endpoint, cardiovascular death, non-fatal MI, ischemic stroke, or unstable angina requiring hospitalization. Also, there was a significant 15% reduction in the all-cause death in the alirocumab group versus placebo group. So based on all these data, in few slides, I will highlight the position of the PCSK9 inhibitor in the current and the latest guidelines. This is the 2018 AHA-ACC guidelines on the management of blood cholesterol in patients with very high risk atherosclerotic cardiovascular disease. Class 1 recommendation to start high intensity or maximum tolerated dose of statin, and the class 1, if PCSK9 is considered, add ezetimibe to maximum statin before adding PCSK9 inhibitor. This is class 1. And they gave class 2A that we can or may should be considered, or it is reasonable to add PCSK9 inhibitors directly to the high intensity statin even before adding the ezetimibe first. And this recommendation or this approach was supported as efficacy, but they mentioned that this approach is less cost effective. In the 2019 European guidelines for the management of dyslipidemia, is class 1 recommendation level of evidence A for secondary prevention in patients at very high risk not achieving their goal on maximum tolerated dose of statin and ezetimibe combination with PCSK9 inhibitor is recommended. Also for the very high risk familial hypercholesterolemia patient that is with atherosclerotic cardiovascular disease or with another major risk factor who do not achieve their goal on maximum tolerated dose of statin and ezetimibe, combination of PCSK9 inhibitor is recommended as class 1 level of evidence C. In patients with heterozygous familial hypercholesterolemia, class 1 also treatment with PCSK9 inhibitor is recommended in very high risk familial hypercholesterolemia patients if the treatment goal is not achieving on a maximum tolerated dose of statin plus ezetimibe. In patients with peripheral arterial disease, including carotid artery disease, class 1 level of evidence A, that lipid-lowering therapy, including maximum tolerated dose of statin plus ezetimibe, or a combination with PCSK9 inhibitor, if needed, is recommended to reduce the risk of atherosclerotic cardiovascular disease events. In patients with acute coronary syndrome, and I'm sure Professor Hani will cover this issue in details, class 1 level of evidence B, that if the LDL goal is not achieved after 4 to 6 weeks despite maximum tolerated statin therapy and ezetimibe, adding PCSK9 inhibitor is recommended. And they gave class 2A recommendation for patients who present with acute coronary syndrome and whose LDL levels are not at goal despite already taking a maximally tolerated statin dose and ezetimibe. Addition of PCSK9 inhibitors early after the event during hospitalization for acute coronary syndrome should be considered. And this is the American Association of Clinical Endocrinology Guidelines 2020. They recommend the use of PCSK9 inhibitors in extreme risk patients and very high risk patients, and they recommend addition to high intensity statin therapy if the patient was not on target. We can add PCSK9 or ezetimibe, and they didn't recommend an order to start ezetimibe first or start PCSK9 first, but they mentioned that starting ezetimibe first will be more cost effective. And they highlighted the agents that can reduce the lipoprotein little a level, and they mentioned the PCSK9 inhibitors as an effective therapy to reduce the lipoprotein little a by about 20 to 30%. And this paper was published in the European Heart Journal 2018, studying the PCSK9 inhibitor evolocumab on the level of lipoprotein little a and the particle kinetics. In the American Diabetes Association Guideline 2021, for patients with diabetes and atherosclerotic cardiovascular disease considered very high risk using specific criteria, if the LDL not at goal on maximum tolerated statin dose, consider addition of ezetimibe or PCSK9 inhibitors, and they recommend ezetimibe first, may be preferred due to lower cost. And actually all the guidelines, either the European or American guidelines, highlighted the issue of the cost effectiveness. So PCSK9 inhibitors to be cost effective, the cost of PCSK9 inhibitors is recommended to be reduced by about 75% discount, just to improve the incremental cost effectiveness ratio. And this inverse relationship between the improved survival and the incremental cost effectiveness ratio indicates that the economic value of PCSK9 inhibitors can be improved by selecting the higher risk patients to be treated by the PCSK9 inhibitors to get the best benefit and the best cost effectiveness. And finally, this is the IAFA consensus on the usage of PCSK9 inhibitors published in the Egyptian Heart Journal a few months ago, and the conclusion was we recommend the use of PCSK9 inhibitors in addition to statin plus or minus ezetimibe in patients with atherosclerotic cardiovascular disease at very high risk. Also for patients with atherosclerotic cardiovascular disease at very high risk who do not tolerate appropriate doses of at least 3 statins, and also familial hypercholesterolemia patients with clinically diagnosed atherosclerotic cardiovascular disease at very high cardiovascular risk. So my take-home messages, my dear professors and colleagues, randomized controlled trials approved the efficacy and safety of PCSK9 inhibitors in reduction of the circulating LDL cholesterol level and in improving the cardiovascular outcomes. Selecting patients with higher cardiovascular risk would improve the economic value of PCSK9 inhibitors. Efforts to reduce the cost of PCSK9 inhibitors should be taken in consideration in order to improve the incremental cost effectiveness ratio. And thank you for your attention.
Thank you, Professor Walid. Actually, شكرا ان انت عندك، انا عارف انك عندك سفر بعد الميتنج ده على طول او بعد المحاضره بشويه، فشكرا يعني لتاهيله، ومحاضره يعني جميله، واسيب البانل to discuss you in the guidelines.
دكتور وليد بنشكرك الحقيقه، great presentation. في نقطه بس انا عايز استوضحها منك ويمكن مش واضحه قوي في الجايد لاينز. انت قلت طبعا ان في كذا ستادي بتتكلم على الافكت اوف PCSK9 inhibitors على اللايبوبروتين ليتل A. And all of us know that we have some residual risk even after achieving the LDL goal. Still some patients can suffer from recurrent ischemic events or atherothrombotic events, even with an LDL less than 55 and even less than 40 in some patients. Do you think that in the future the guidelines will include the PCSK9 inhibitors in this subset of patients who achieved the goal of LDL but still having recurrent atherosclerotic or ischemic events?
Thank you, Dr. Salim, for the excellent comment. Actually, yes, absolutely, you are right. Even with very low levels of LDL, still we have residual risk. And the residual risk may be not just because of the LDL, because it's already at target, but because of other residual, maybe lipid residual risk and also inflammatory residual risk. Just as maybe the low HDL, the high triglycerides, and high lipoprotein little a, the inflammatory residual risk, just like the high sensitive C-reactive protein, also the tumor necrosis factor alpha, the interleukin, all of these factors should be addressed, because even with LDL as a target and all of these parameters still not controlled, the patient is still at risk. So the therapy that can attack more than one target of all these parameters will get the will make the greatest benefit. So PCSK9 inhibitors is one of those novel therapy that can significantly decrease the LDL, as well as it also affects the lipoprotein little a by increasing the catabolism of the lipoprotein little a, which is a strong risk factor for cardiovascular events. Also, the addition of PCSK9 inhibitors to statin may bypass the statin escape phenomenon, as shown in one of my slides and also by Dr. Atif, and this can explain what is called the rule of 6 of statin. But by doubling the dose of statin, cause just 6% reduction in the LDL, maybe this is because the statin escape phenomenon by increasing the expression of PCSK9 that cause degradation of the LDL receptor, and this pathway can be antagonized by addition of PCSK9 inhibitors.
I want to add a note here, BNB, the triple therapy of dyslipidemia in patients with acute coronary syndrome. Now, there is a direction in all Europe, the whole Europe, that those patients admitted to the ICU in acute coronary syndrome will have the triple therapy, high intensity statin, plus ezetimibe, plus PCSK9.
هو الصوت مقطع عند عاطف ولا النت عندي ضعيف انا؟
انتوا سامعيننا يا جماعه؟
سامعين دكتور عاطف، سامعين دكتور اشرف.
تمام.
سامعينك يا باشا، سامعينك، اتفضل.
تمام. وانا شفت بعض الارتكلز جديده في اليوروبيان سوسايتي اوف كارديولوجي جورنال على التريبل ثيرابي ده، واضح ان الجايد لاينز will be directed to in the future to the triple therapy زي ما عملوا مع الهايبرتنشن، على اساس ان يبقى ده كل ده علشان البيشنت ويز اكيوت كورونري سيندروم.
انا عايز اوافق على كلام حضرتك يا دكتور عاطف، وكنت يمكن لسه هكلم دكتور وليد في الحته دي دلوقتي، ان احنا if we have a patient of acute coronary syndrome and we have, as we all know, to not only to keep the lower the better, but also the earlier the better. And one of those patients who subjected to acute event with LDL of 200 or 220, what we are expected from a high intensity statin, which will reduce by maximum 50% of the basal LDL, we will reach about 110 and we will be far away from the target. So I think we will delay the patient, and in this vulnerable period, the patient may be again subjected because of the vulnerability of the plaque to another fatal attack. That's why I think this is concept will be changes in the coming evidences in the guideline. Do you agree with me, Professor Walid?
Yes, Dr. Said, I agree absolutely about the combination therapy and the triple therapy, as Dr. Atif said and Dr. Said said also. But the only barrier, it's my opinion, the only barrier for the widening the spectrum of usage of PCSK9 inhibitors worldwide, not just in Egypt, is the cost. So this issue, it's a big problem. And
needs Walid, it needs a cost-effective studies. Why? Because of the patient is subjected to another attack, it will be much costly than giving the PCSK9. So we have to convince the authorities to do somewhat they can do for those patients for secondary prevention for those very high-risk patients to let the PCSK9 and those combination therapy available for them, because this is actually costless. This is actually costless because those patients, if subjected to another attack, it will be much more costly for the government.
Yes, Dr. Said, actually there is some debate about this, because in some countries they recommend the reduction of the cost because they estimated the life the year cost of the use of PCSK9 inhibitors for one patient, it exceeds $14,000. $14,000, and for some countries this may exceed the cost for hospitalization, for example, for second time. So, I think this is relative.
I think it needs a cost-effective.
In some countries, and it will be of low value in other countries.
Yes.
ولا شك ان طبعا لو الكوست بتاعه قل البيسكي9 انهبيتور، كتير مننا هيستخدموه اكتر بكتير من ان احنا بنستخدمه ما زلنا حتى الان. انا I will move to the second sessions. Professor Osama Sanad, Tamer, Said Farag, lead the mic for the second session. اتفضل دكتور اسامه.
اشرف والاساتذه الافاضل، انا بس اساسا حضراتكم بس كنت مرتبط بسفر.
شكرا يا وليد.
انا بعتذر بس عشان مرتبط بسفر بس دلوقتي والله.
لا شكرا.
بالتوفيق ان شاء الله، بالتوفيق.
شكرا جزيلا، شكرا جزيلا.
First الصوت مسموع؟
سامعينك يا اسامه.
Good afternoon, my dear colleague. Actually, we are enjoyed with two sessions, Dr. Atif and Dr. Walid. And now we are going to very hot topics. The first is for Dr. Ahmed Bindari, which is known for all. Actually, when he learned to be from Banha, lecture of cardiology. He will discuss with us a difficult case to reach the goal in familial hypercholesterolemia. تفضل دكتور أحمد.
Thank you, Professor Osama, for this nice introduction. At first, I'd like to make sure that the presentation and the voice are okay for all.
Yes.
Yeah, okay.
Good evening, all, another time. Thanks for the IAVA board and specifically for my dear Professor Dr. Ashraf Rida for inviting me. It's always a great pleasure to be with you all. Today, after we heard the basic science behind the PCSK9 and the PCSK9 inhibitors position in the guidelines, I'd like to dig deeply into what is already being done in Egypt regarding the management of the highest risk patients for whom PCSK9 inhibitors are very targeted, those patients with familial hypercholesterolemia. Friends, remember that science can tell us what we can do. The randomized controlled trials tell us what we should do, and what we are in front today is the registry, which tells us what we are really doing. I'd like to give you a hint about the Familial Hypercholesterolemia Research Collaboration, which is a multinational project to study the prevalence and the treatment management strategies for patients with FH. Egypt is one of 3 African countries which contributed data to this important multinational global project. The national leader in Egypt is Professor Ashraf Rida, and there are another 14 investigators, academics and non-academics from all over Egypt who have thankfully contributed important data about FH to this project. Importantly, please stay tuned for our publication in the European Heart Journal supplement and the important upcoming publication in The Lancet, which comprised more than 60 countries contributing data to the Familial Hypercholesterolemia Research Project. And now to the important part of the presentation. Actually, until recently, no data were available about the prevalence of FH in Egypt. But thanks to the CardioRisk project and thanks to some statistical methods, we successfully obtained the estimated prevalence of familial hypercholesterolemia among those very high-risk patients, the Egyptian ACS population. And among 3,224 patients, of whom 2,743 patients with available LDL cholesterol level, we determined that the estimated prevalence of definite FH according to the Dutch Lipid Network criteria is 0.1%. And the prevalence of probable FH is 0.25%. And sit down for this, the prevalence of possible FH among Egyptian patients with ACS is approaching 17%. This means that 17 out of every 100 Egyptian patient with ACS is usually having a possible FH. This is a pretty high number. And this is how things were going in the FHRC. The contributing investigators contributed data to the data collection center, which I was honored to be the responsible person for that. And then I passed these data to the national leader, who is Professor Ashraf Rida, and then Professor Ashraf Rida, together with the other national leaders, provided their data to the FH Global Center, which is located in the Imperial College London. And these are the things were done. And we had 3 portals for entry of the data. The first is the web portal through which the data were uploaded to the coordinating center in the Imperial College London, whose main function was ETL. The E stands for to extract the data, The T stands for to transform the data, because the data were transmitted heterogeneously from different centers all over the world. And finally, the L stands for to load the data into what's called the FH data warehouse. And finally, we had another web portal through which the data were analyzed and the results were generated. And now to another important piece of the presentation. These are the baseline criteria of the Egyptian FH patients. From the period of August 2017 to March 2021, we successfully obtained data from 2,228 FH Egyptian patients. 46% of them were males. In other words, the majority were females, and this is important. The mean age of those populations was relatively young. It was just 48 years old, and this is important. 3/4 of those patients came from urban residents, and the mean body mass index was 30 kilograms per meter square, which means that the mean population of the FH in Egypt are approaching the overweight and the obese boundary. And the average time from the diagnosis of FH to enrollment into our registry was 7 years. And this represents what we call a gap in executing the clinical research in those patients. Suffice to know that a patient had to wait 7 years from being diagnosed with a serious condition such as FH until he or she became involved or enrolled into a formal registry. Regarding the concomitant risk factors to the Egyptian FH patients, the #1 ranking, as you know and as you can expect, is hypertension. This was followed by smoking. This was followed by diabetes, which was prevalent in 18% of those patients. And finally, CKD was present in only 0.9% of those population. And how did we diagnose those patients? Actually, almost all the time, the Dutch Clinic Lipid Network criteria was used. This is because it's easy and it comprised different clinical and laboratory and even genetic testing to generate a very elaborate score. But unfortunately, this genetic test was done in only one patient among our 228 patients, and it was found to have a heterozygous FH defect, and the defective gene was the ApoB gene. And the figure on your right hand represents the distribution of different categories of FH patients. The vast majority, as you can expect, 75% were belonging to the possible FH category, and 11% were belonging to the probable FH category, and 14% of our patients were belonging to the definite FH category. And this is the master slide of the presentation. Please look with me to the lipid profile of the Egyptian FH patients and sit down for this. The mean total cholesterol was 316. The mean LDL was 237. Please remember, I am speaking about the mean. This means that many patients are above this number. Suffice to know this number. The HDL mean was 47. The median triglyceride was 119. And for those patients for whom lipoprotein little a was done, the mean level was 42. Friends, these are very high numbers. We are speaking about Egyptian FH patients. Some of those patients are well treated and still have these high numbers. And when looking to treatment strategies employed for our Egyptian FH patients, it looks a little bit pretty good. All patients except one patient received lipid-lowering therapy. And when we look to the distribution of statin therapy between the two major members of high-intensity statin therapy, atorvastatin and rosuvastatin, we will find that 226 out of 228 patients received statins, and this was equally distributed between rosuvastatin and atorvastatin. But sadly, only one patient had successful LDL apheresis, and this represents a huge underutilization of different treatment strategies for those very high risk or high risk patients. And when looking deeply into the non-statin combination, we found that 44% of the patients suffered with the monotherapy in the form of high-intensity statins, and 56% of the patients received other non-statin therapy in addition to statins. And this is the distribution of other non-statin therapy. The vast majority, more than 55% of those patients receiving combination lipid-lowering therapy received the ezetimibe. Yes, it's cheap and widely available. And about 8% of those patients received fibrates as non-statin combinations. And unfortunately, only 2.6% of those patients received PCSK9 inhibitors. And this is another reflection of the huge underutilization of the important therapeutic armamentarium we have today to treat those patients. Finally, only 1% of patients received omega-3 fatty acids. And when looking into the reason behind the low utility of PCSK9 inhibitors in the Egyptian patients with FH, I and many expect that the time period of the study, which extended from 2017 to early this year, 2021, was above the era we live today, the era of PCSK9 inhibitor widespread adoption in the guidelines for those patients, and we may expect an uptake in the penetration of PCSK9 inhibitors for clinical practice in those patients within the upcoming few years. Now, I'd like to pick 2 or 3 real cases from this Egyptian registry in order to explore how we are treating those patients and how are their numbers good. First case is the case number 123 in the registry, which was a female patient, 12 years old, coming from Minopharia, and she is a resident in an urban area. Her body mass index is 20. She is not obese. She had a history of aortic valve disease, aortic stenosis, as you can expect in this young age and these high numbers that I will present. And she had a family history of premature coronary artery disease. Her blood pressure was 160, heart rate was 80, but she had xanthomas, tendon xanthomas, vancomyelitis, and even corneal arcs. No genetic test was done, and this is the sad point number 1. But according to the Dutch, as we will see in the next slide, she had a definite FH category, diagnostic category. And these are her numbers. Total cholesterol 678 milligram per deciliter. LDL cholesterol 616, yes, I said it correctly. Triglycerides 107, HDL 30. And when looking to her treatment, she received atorvastatin 40 milligrams. And the question here, why didn't she receive the highest intensity statins? For 2 main reasons. The first, that she had some statin-associated muscle symptoms, and the second is that the highest dose of statins in children is still, up till now, questionable. She didn't have ezetimibe. She had evolocumab, subcutaneous injection, 140 milligrams every 2 weeks. Some will question this dose, but this dose was the dose that was given, and LDL apheresis is being arranged for her. The last LDL cholesterol for her was 210 milligram per deciliter, down again from 616. And this is the question number 1, and the message number 1 I'd like to convey. Even with a high or even a moderate intensity statins, and a PCSK9 inhibitor, those patients are difficult to control, still have high numbers. And the question is why? Number one, as our colleagues said, Dr. Saeed Farag and Professor Saeed Farag and Professor Walid Abdo and Professor Atif Al-Bahari, statins have what we call a ceiling effect. Whether atorvastatin or rosuvastatin, you cannot reach beyond 50 or 55, maximum 60% reduction from LDL cholesterol with a very wide interpersonal variability. The second is that if you combine PCSK9 inhibitor plus high-intensity statin, you can reach down to 75%. And if you added ezetimibe, you can reach down to 85% reduction from the baseline. But if you looked into the patient, she didn't have the highest dose of atorvastatin, and the dose of evolocumab in her was questionable. This patient mostly is having some form of homozygous FH, despite the fact that she didn't undergo a formal genetic test. And the recommended dose of evolocumab for her should be 420 milligrams every month, to be increased every 2 weeks sometimes. The second case is case number 14 in the database, which was again a female, 31 years old, from Zagazig, and she is a resident in a rural area. Her body mass index was 24. She had no other risk factor. She had a history of chronic kidney disease stage 2, and she had a family history of premature coronary artery disease. Her blood pressure and heart rate were normal, but she had tendinopathies and benzylazmy. Again, no genetic test was done. Remember, genetic test was done in only one patient among the 228 Egyptian FH patients. This reflects a huge unmet clinical need. And according to the Dutch, as you will see in the next slide, she had a definite FH. And these were her lipid profile and other labs. Total cholesterol was exceeding 747. The LDL cholesterol was 701. Yes, 701, a very large number. Triglyceride 103, HDL 23, and the eGFR was 65. Remember that she had stage 2 chronic kidney disease. How was this patient treated? This patient received statins, atorvastatin 80 milligrams, received ezetimibe, received alirocumab 75 milligrams subcutaneous injection every 2 weeks, and she had a successful access to LDL apheresis. Remember, LDL apheresis was used in only one patient in our registry, and this is the patient which used LDL apheresis. The most recent LDL cholesterol for this patient was 113 milligram per deciliter, which is okay, a good number, but still beyond the recommended goal for this patient, which should be, as the guidelines told us, 55 milligram per deciliter. The third and the last case is case number 70 in the database. And now we are in front of a male who is 50 years old, 50, from Alexandria, and he's a resident in an urban area. His body mass index was 26. He is a smoker 1 by 1 with history of ischemic heart disease and PCI, I think, to the LAD many years ago, with a family history of premature coronary artery disease. His blood pressure and heart rate were normal, but he didn't have the ensoulment, benzylazmy, or corneal arcs. Those classic clinical signs for FH. And this is the tricky point number 1. This patient had a successful genetic test for a reason or another, and this patient was found to have a heterozygous defect in the ApoB gene, and according to the Dutch, and I will present this in the next slide, he had a definite FH. And now, let's look to his lipid profile. Total cholesterol was 251, and this is a usual number we encounter today in daily practice. The LDL was 171. Yes, this is a common number we see every day in the clinic. triglyceride was 241, HDL 32. And the big question is, how come the LDL cholesterol of 171 translates into a definite FH category according to the Dutch? And this is the teaching or the learning point number 2. If we look into the Dutch lipid clinic criteria, we will find that they depended on many factors other than the LDL cholesterol level. We have the family history, the clinical history, the physical examination, in addition to the DNA analysis. This patient had a clinical history of premature coronary artery disease. His age is 50, and still he had many years ago a PCI to the LAD. And this patient had an access to a DNA analysis showing a heterozygous defect in the ApoB gene. So if you sum these 8 points with these 2 points, you will have 10 points, which is quite higher than the 8-point threshold to diagnose a definite FH. The teaching point in this case is that you can have a definite FH with a reasonable common number of LDL cholesterol. LDL cholesterol level is not everything. You have the genetic test, you have the family history, you have the clinical history, and even you have the physical examination. And if we look into the treatment of this patient, we will find that this patient received rosuvastatin 20 milligrams, received the estimide, received the evolocumab 140 milligrams subcutaneous every 2 weeks. And of course, we are not in need of LDL apheresis in this patient, simply because his recent LDL cholesterol was 49, and this is exactly meeting or below the target for this patient, which is 55 milligram per deciliter. For conclusion, from the Egyptian part of the Familial Hypercholesterolemia Research Consortium, is that the Egyptian part of this registry, to best of our knowledge, is the first FH registry in Egypt all over the time. Our data show that the electronic CRF system is feasible and reliable. We succeeded to obtain the data from more than 200 patients through the electronic CRF system. The phenotype of enrolled patients showed a higher female preponderance, very high levels of lipoproteins, and unfortunately inadequate therapeutic interventions with huge underutilization of LDL apheresis and of course PCSK9 inhibitors. And we think that this is a call of action in order to mitigate these management gaps for this high risk patients. Thank you for listening. I'm grateful that you listened. This was me, Ahmed Bindari, signing off, and goodbye.
Thank you, Bindari. And actually, الحقيقة Bindari helped me a lot in this project. احنا بدأناه few years ago بالفاميليال هايبركوليستريميا ريسيرش فورم اللي كنا بنعملها في رمضان كل سنة، نفطر في رمضان، وابتدينا نجمع حالات من الكونسلتنت والأساتذة والأخصائيين اللي معانا، وأحمد بنداري ومحمد بنداري جريت ستاتيشنز الحقيقه في بنها ساعدنا جدا في الاحصاء وفي الاكسترابوليشن اوف داتا. والحقيقه ثانك يو بنداري ان انت اظهرت الدراسه في البرزنتيشن الجميله ديت الحقيقه اللي يا ريت توزعها علينا علشان نستخدمها في البرزنتيشنز بتاعتنا. انت جمعت تجميع حلو قوي من الداتا.
انا لسه قايل له دلوقتي حالا على الواتس.
Actually, Dr. Ahmed, thank you for this very nice.
جميل يا أحمد، جميل.
Thank you, Professor.
Very nice English language. But you ended your presentation with a question. Actually, the Egyptian familial hypercholesterolemic patients, especially those with acute coronary syndrome, are undertreated. So, what do you think? How can we solve this problem?
ما تفتحش في الاكيوت كورونري سندروم يا بنداري، الدكتور هاني هيقول لنا اكيوت كورونري سندروم.
Yes.
I mean familial hypercholesterolemia.
Okay.
Dr. Osama are speaking about the clinical situation in Egypt. We present.
كلنا we are waiting for acute coronary syndrome and PCSK9 inhibitor from him.
اوكي اتفضل يا بنداري.
I think first we need to convince the health authorities, whether the governmental sector or even the private health insurance system, about the importance of these medications in terms of reduction of some hard clinical endpoints. But at the same time, the price of these medications and the cost effectiveness all over the world is still a great question. For example, in the United States, the quality adjusted life year, or what's called EQALY, for each person to live 1 year without any health is equal to $30,000 to $40,000. And this is exceedingly equal or even higher than the price of these medications. In Egypt, we still have a great lack of a formal cost effectiveness studies regarding PCSK9 inhibitors, simply because in Egypt we don't know the quality, how the quality equals how much pounds in Egypt. The price of 1 year of good health for every Egyptian citizen equals how much pounds we don't know. But if the
5 Egyptian pounds.
But if the pharmaceutical industry succeeded to have some price cuts by any means, and we as a scientific community have the chance to convince the governmental or the private health authorities, I think we will witness a widespread penetration of these important medications in the market within the upcoming 2 or 3 years.
We vote for Professor Dr. Ashraf Rida to take this lead for the authorities. We can go, we can select some of us with Dr. Ashraf, because it's our community. We have a real society now. We have an impact. We have consensus. We have good eminent professors. We should put an impact not only in lectures and presentations and in conference and education, but to put an impact on the health system, not to leave this system for anyone. Because if familial hypercholesterolemia, dyslipidemia, this is ours. This is our task. And I think Ashraf can agree with me with that.
Dr. Atif, Dr. Ashraf, and I agree with Dr. Atif. What about notes to define familial hypercholesterolemia, how to diagnose, and the guideline for management? This is the first. And second, what about, you have mentioned before last year ago, about lipid clinic in some hospitals?
Important questions. All of these questions, I think, need good collaborative works, and it needs teamwork to get use of this important data. ممكن كلنا نساعد فيها ان شاء الله. I think ان احنا نبروسيد في البرزنتيشنز علشان الوقت وعشان الناس ما تسهرش معانا. اتفضل يا دكتور اسامه. تالي السيد فرج وتامر مش معانا، فاسامه.
Dr. Hani, all of us are waiting for your presentation about acute coronary syndrome and the use of PCSK9 inhibitors. Is it for all patients or for some patients?
Thank you very much, Professor Osama Sanad, and thank you. It's so nice to see the entire EAVA panel. I'm sharing my screen now. Can you see my first slide?
Yes, we see.
Okay. I would also like to thank Amgen. This is Amgen help in the presentation, and these are slides of the European Society of Cardiology. So in the 2019 ES guidelines for the management of dyslipidemias in lipid modification to reduce cardiovascular risk, and it's very, very important that we do notice that large societies are now producing common guidelines. This is something which is very helpful for cardiologists and other subspecialties like diabetologists. So more intensive and aggressive reduction in LDL cholesterol across cardiovascular risk patients using PCSK9 has finally found a place in the guidelines in both atherosclerotic cardiovascular disease and acute coronary syndromes. So in patients at very high risk with persistent high LDL cholesterol despite treatment with maximally tolerated statins and in a combination with ezetimibe, or in patients with statin intolerance in ASCVD, a PCSK9 may be considered. But if you're talking about secondary prevention, that was primary prevention. If you're talking about secondary prevention, and that is orange, but look at the green. For secondary prevention, patients at very high risk or not achieving their goal on a maximally tolerated dose of statin ezetimibe, here a PCSK9 is not just to be considered, it's actually recommended. And for very high risk familial hypercholesteremia patients that we were just talking about in Professor Benderi's beautiful presentation, and those are patients with atherosclerotic cardiovascular disease or other major risk factors who do not achieve their goals on a maximum tolerated dose of statin ezetimibe, again, a combination with a PCSK9 is recommended. Now, what about ACS? It's yellow. So lipid-lowering therapy in patients with ACS. For those patients with ACS whose LDL cholesterol levels are not at goal, despite already taking a maximally tolerated statin PCSK9 and ezetimibe, adding a PCSK9 inhibitor early after the event, between brackets, if possible, during hospitalization, during the index hospitalization for the acute coronary syndrome event, should be considered. Why is that? Let's look quickly. I remind you of the Fourier, which I'm sure you have heard so many times. So I'll be very brief and just get a couple of pertinent slides. Repatha outcomes trial, the evolocumab and clinical outcome in patients with cardiovascular disease. Look at this. That is the age we're looking at, 40 to 85 years. Patients who've already had an infarction, a myocardial infarction, a stroke, or peripheral arterial disease, who have additional risk factors, or optimally background therapies. They're receiving effective doses of statins and ezetimibe, whose LDL is still more than 70, equal or more than 70, or non-HDL, which is a better way to look at cholesterol, is more equal to or more than 100 milligram per deciliter. As you know, we're randomized to either evolocumab once every 2 weeks or once every a full dose every month, per patient preference. This is the only dose available in Egypt, so our patients would be once every 2 weeks, versus placebo. And the placebo included standard of care treatment, maximum dose statins and ezetimibe, and the patients were followed to the end of the study. Of course, you know that the primary endpoint was a composite of cardiovascular death, MI, stroke, and hospitalization for unstable angina or coronary revascularization. The key secondary endpoints were a composite of cardiovascular death, MI, and stroke. And other secondary endpoints were death, stroke, coronary vascularization, cardiovascular death or hospitalization for heart failure, or ischemic stroke or transient ischemic attack, all looked at separately. And the efficacy analysis was hierarchical. So if a primary endpoint was significantly reduced, then the key secondary endpoints were to be tested, followed in order by cardiovascular death, all-cause mortality, then additional secondary endpoints. So excellent statistical methodology. Now, it's very worth mentioning that out of 13,000 patients in the evolocumab, 13,000 plus in the evolocumab group and the placebo group, more than 11,000 patients in each group had had a myocardial infarction. This is extremely important because this is big enough to look at. The time from the most recent prior infarction was on average about 3 years and 3 months. The primary endpoint, which is the composite of death, MI, stroke, the primary endpoint was reduced by evolocumab on top of excellent care, which was called placebo. It's not really placebo. A 15% relative risk reduction with a good hazard ratio and a good confidence interval and a very impressive p-value. And as you know, this led evolocumab to the guidelines. the secondary endpoints was even better. There was a relative risk reduction of 20%. So what about the patients in the Fourier, the 11,000 patients in each group? That's more than 22,000 patients who actually had a history of myocardial infarction. They were later studied separately because this is an important group. And look at this. If the infarction was relatively recent, you remember the average was 3.3 years. So if the infarction was relatively recent, less than 2 years, the relative risk reduction was bigger. It was 24% compared to a more remote myocardial infarction. And the number needed to treat with evolocumab to achieve a reduction in the primary endpoint was only 35 patients. While if the infarction had been remote, more than 2 years, the number goes up to about 100 patients. And, the level of statistical significance is different. You can see here it's quite statistically significant. Now, what about if the patient had had more than a myocardial infarction? Because that obviously means it's more risky patients with other ongoing risk factors. Again, you see the same thing. The number needed to treat is quite small, only 38 patients. If you have had more than 2 MIs, and there's a 21% relative risk reduction, or if you've only had 1 MI, the number needed to treat is 60, and the P is still significant, but the relative risk reduction is slightly less. So you get benefit in all groups, but it's more benefit if the infarction is more recent, and it's more benefit if there has been more than 1 infarction. So if you look at patients who based on multivessel disease, if they've had multivessel disease, you have 30% relative risk reduction, and the number needed to treat of only 29. Well, if they have no multivessel disease, they have 11% relative risk reduction, and the P is approaching significance, not significant, and the number needed to treat is 78. So remember that. Recent infarction, more than 1 infarction, 2 or more, and multivessel disease. So the patients who are closer to the most recent infarction, the patients who have had prior MIs or with multivessel disease are at the 4 to. These patients experience substantial relative risk reductions and absolute relative risk reductions over 3 years when you use PCSK9 evolocumab for intensive lipid lowering therapy. And we could see that in large numbers of patients, more than 11,000 patients in each group. The new data from the Fourier evolocumab in recent MI patient, the patient who had an MI 1 to 12 months ago, was also presented in 2019 at the American Heart, which is the evolocumab and cardiovascular outcomes in patients with a recent MI analysis from the Fourier. Again, the median time from the MI in months was 4.8 months for the recent MI group and 59 months for the remote MI group. And these are there's no major difference in patient characteristics. Here are the difference. There's slightly less hypertensives in the recent MI, slightly less diabetics. You can see it for yourself. I don't want to read this, the slides because it's going to take too long. The 3-year event rate in recent versus remote. Again, recent in orange, the incidence of the primary endpoint versus remote in green. The patients have a higher risk if they've had a recent MI. And the key secondary endpoints, again, the patients have a higher risk if they've had a recent MI. And if you use evolocumab, you get significant reduction in this risk in those patients with recent MI. In recent MI, you get a 19% relative risk reduction, and the number needed to treat is only 27. While in remote MI, which would have been a few years, the relative risk reduction is only 8%, and the number needed to treat is 95. You can still use it, but if you want to get the big benefit, if you want to put those expensive drugs at this point in time in better use. Look at this data. So the key secondary endpoints, cardiovascular death, MI, and stroke with evolocumab, were reduced in recent MI patients with a 25%. The last slide was the primary endpoint. This is the key secondary endpoints. Again, you only need to treat 32 patients to help one avoid death, MI, or stroke with a 25% relative risk reduction, while in remote MI, you have to treat nearly 80 patients to help one with a 15% relative risk reduction. So in summary, the patients with recent MI were at a higher risk of major adverse cardiovascular events compared with those with a remote MI. And in the recent MI patients, evolocumab reduced the risk of the primary endpoint with 19%, with a number needed to treat of only 27 patients over 3 years to save them the risk of a cardiovascular death, MI, or stroke. And those are the secondary endpoints, which each was, they were looking at the secondary endpoints. A reduction was 25% with a number needed to treat of 32%. The first one was the primary endpoint, was the composite endpoint. So in conclusion, the findings corroborated the 2018 ACC/AHA guidelines recommendations to extensively lower LDL cholesterol after recent MI, preferably when the patient was still in hospital. And we know now from this data which patients to choose. So this is a recent MI, this is exactly what you want. And of course, if this patient had had a previous MIs, it even becomes a stronger indication. And if you know their anatomy and they have multi-vessel, an even stronger indication. So the EVOPAC study, these are my last few slides. I'm not going to take a long time. The evolocumab for the early reduction of LDL cholesterol levels in patients with ACS, the EVOPAC study, was a randomized, double-blind, placebo-controlled, multicenter study, which was presented in August 2019 by Dr. Koskinas. And the primary endpoint was a change in LDL. It was just looking at the LDL from baseline to 8 weeks. The safety endpoint was safety and tolerability. There were exploratory endpoints, which was high-sensitive C-reactive protein and other inflammatory biomarkers, platelet reactivity, contrast-induced acute kidney injury, and post-PCI myocardial injury. This was the study, evolocumab subcutaneous plus atorvastatin versus placebo versus atorvastatin. 40 milligram atorvastatin was used. The patients were tested at the beginning for fasting lipids, inflammation, troponin, EGFR, and all through for fasting lipids, and at week 8 for fasting lipids, which was the primary endpoint, and the inflammatory exploratory endpoint of inflammation. And the results, the index ACS event, about 37% of the patients were STEMI, 63% were non-STEMI. All STEMI patients, 100% of them were started on evolocumab, were enrolled within less than 24 hours. For the non-STEMI patients, 40%, nearly 39% were in less than 24 hours like STEMI, and 61% within the first 3 days. The treatment of the index ACS event was, as you would expect, by PCI in the vast majority of patients, 84%, and equally divided numbers of medical therapy and bypass. The statin treatment at baseline, as you expect, a lot of patients who come to hospital with an acute event who had not sick before were not on statins. 78% were not on statins. Low and moderate intensity statins were in 11.4%, and high intensity statin on 10%. That is, you have to use your converters. For the milligram per deciliter, but this is nearly 70. 2.3 is about 6. Those not using statins was over 100. 3.4 is 132. 3.6 is 139. 2 is 77. And the group which received the evolocumab, as you can imagine, they dropped their LDL to 30. very quickly, which was very highly statistically significant. So the group which was treated by maximum statins and ezetimibe, the mean LDL was 80 at the end of the study, and the group which was treated with evolocumab dropped it to 31, which was a drop of more than nearly 41%, and was highly statistically significant in the 8-week duration of the study. The achievement of the LDL targets of less than 70 or less than 55, if you look at the ESC, EAS dyslipidemia guidelines, which were again beautifully presented today in the first presentation, was much, much better with evolocumab. You reach the guidelines in 95% of the 95.7% of the patients, compared to only less than 40% for patients on maximally tolerated statins and ezetimibe. And at week 8, the LDL target of 55 was only achieved in less than 11% of patients on maximally tolerated statins on ezetimibe, compared to more than 90% in the evolocumab group. Now look at this. This is what you want your patients who are at very high risk in hospital with a STEMI or a high-risk non-STEMI to reach. And you basically will reach that target in more than 90% if you use evolocumab. If you wait and use standard treatment to see if it's going to work or not, you're going to end up having to use evolocumab or PCSK9 in nearly 90% of the patients. So the guidelines say start while they're still in hospital. In summary, in the patients presenting with ACS and elevated LDL cholesterol levels, in hospital initiation of evolocumab on top of high-intensity statin therapy for 8 weeks, achieved average LDL levels of 0.79, which is 31, versus 80 milligram per deciliter with statin alone. It made more than 90% of the patients versus only 11% of placebo-treated patients within the current recommended target levels. I hate using the word placebo here because it's not placebo. It's high-dose statin plus high-dose statin plus ezetimibe. It was safe and well-tolerated during the short duration of the study and did not result in measurable differences of any of the surrogate biomarkers. So the PCSK9 did not save the kidney from contrast during CAT. This was a bit of an ambitious point to study. Thank you very much, and I'm happy to take any questions. I'm stopping.
Thank you, Hani, and actually, excuse me to allow one question or comment before the presentation of Ahmed Shawqi, to be strict to the schedule of time.
Sure.
If any of the panel have any comment or question for Professor Hani.
Yes, I want to ask. First, thank you, Mr. Dr. Hani. EVOMAC trial is a small number, about 310, I remember. Do you expect that the intake of EVOMAC before or after 24 hours in acute coronary syndrome will change the outcome of BCI?
No, I don't think. I think, like you said, this was an 8-week study, and this was not studied. The only thing which was studied was the number, bringing our patients to targets. So as you know, cholesterol is very inflammatory, and bringing those patients to target quickly might have an impact on, as we saw, will have an impact on cardiovascular death, will have an impact on other myocardial infarctions, will have an impact on stroke. It is not going to have an impact on contrast-induced nephropathy or lowering CRP. But, I would ask you, Professor Osama, and I'm really curious to hear your answer. If evolocumab was free of charge, and you have STEMI patients and high-risk non-STEMI patients who are dyslipidemic, because some patients, I've had many STEMI patients, young men in Mbaba, who were using a lot of cigarettes and cannabis and who had totally normal lipid profile, you could bring them to target with 20 milligrams of rosuvastatin without even any additional treatment. And the risk factor, their main risk factor was smoking. So of course I gave them statin, but those patients, I just give them 20 milligrams of rosuvastatin. The next thing you know, their LDL is 50, But I'm talking about the patients whose LDL is 110 in hospital, So would you give them PCSK9 if it was free of charge?
Yes, I will give him, yes.
Thank you. I think that's exactly how I feel. The only thing which is stopping us is the cost. Those trials have shown us who are the most risky patients in the ACS groups that we can put our dollar on.
Yes.
I think this is a good introduction to the presentation of Professor Shawqi, who will tell us which patient should we give PCSK9. It's very difficult to choose the patient. We have the cost, we have the risk. So, Professor Shawqi, go ahead.
Thank you, Professor Ashraf. It was a lovely evening. Lots of data, lots of everything. Actually, what and when and how is a very good question. Maybe it's simple to say familial hypercholesterolemia because these patients are at very high risk, but actually positioning of medication and evidence-based medicine is quite important. And how we use and what to use to improve morbidity and mortality is important in this really unmet need, which is the LDL reduction. So let's try and tackle a few questions about this LDL management, when and how and whom and what. This is important. So the first question, do we really need PCSK9? I think this has been really discussed so much, and we know that the most odds ratio for a myocardial infarction is elevation of cholesterol. LDL reduction does not show a J curve. The less, the better, regardless what level we go to. And we know LDL directly affects 4.3 million deaths per year, and this was published just last year. And the guidelines are not just looking at lower and lower levels, they are going with the higher and higher risks. So this is quite an important thing. We look at the hypertension guidelines, they haven't changed a lot, maybe 10 millimeters of mercury in systole or 20 millimeters, but not much more. Look at the LDL guidelines, I think they have dropped more than 50% over the past 10 years. So this is quite a really cumbersome task. And if we look at the data, reaching the goals to the previous guidelines of 70 or below, we can see in acute coronary syndrome in NeuroAspire 5, we're not reaching them in over 7 or 68% of patients, not the 55 to say. And even then, in acute coronary syndromes in Europe, only 60% were on a high intensity statin, which is a problem. DICE showed again 30% were only reaching goals. Cepheus, and Professor Ashraf is the head, only showed 34%, and in the very high risk, only 11%, which was presented today, that shows us we're not really reaching them. But more importantly, even in randomized controlled trials, and this is the newest randomized controlled trials in chronic coronary syndrome, ischemia, you can see the target of 70 milligrams of LDL was reached in less than 60% of patients. Even in randomized controlled trials, which are the best in the advancement of medicine, this is not reached. So not only are the numbers not there, but also the cost is quite an economic burden. And this procedures that we do, especially cardiac cath and PCI and stenting and stuff, is a costly procedure. But what is even more important, the recurrence of events and recurrence of the procedures is even more costly, with more incidence of actually morbidity and mortality. So the survival rate decreases as we get more and more events, and this was shown by Professor Haniraki. So yes, we probably do. And the ESC guidelines in 2019 said we should do that. And they even gave us a hint on when, on how. If you want to go with a 50% reduction, you can use a high-intensity statin. But if your LDL levels are way beyond that, definitely you'll probably reach that in a minority of patients. So if you have a marked elevation then you should go with the PCSK9 ezetimibe even from the start. This is a problem. They do not advocate usage, but they say use it earlier on. Don't wait for the LDL levels to be repeated after 2 to 3 months. Repeat it after 4 to 6 weeks, and then add ezetimibe, then add PCSK9. So yes, a lot of patients will require that. Is this an important subject? Yes. Is the benefit of PCSK9, is it just LDL reduction? Because we've seen a lot of medications reduce LDL, or is it also the reduction of cardiovascular events and death? Because we see this in hypertension. All medications reduce the blood pressure, but are all medications beneficial for the patient or not? First of all, 2016, the guidelines really took a pillar, which was the Fourier trial by evolocumab, and it showed in patients at high or at very high risk with established cardiovascular disease, whether a myocardial infarction, whether a stroke or a PAD, there was a significant reduction of cardiovascular death, myocardial infarction, stroke rates, coronary revascularization, and hospitalization for unstable angina. So not only was there a 50 to 60% extra LDL reduction, there was a significant reduction in cardiovascular outcomes. This is a difference between PCSK9 inhibitors, ezetimibe, statins, and, for example, fibrates. These medications have shown a mortality reduction. These have shown benefits for the patients. Even in the secondary endpoints, cardiovascular death, myocardial infarction, and stroke rates were significantly reduced, and the p-value you can see is quite evident, a 20% relative risk reduction. And this included every parameter. It was not driven by a single parameter. It was driven by a reduction in myocardial infarction significantly, around 27%, stroke rates around 21%, and 22% coronary revascularization. So this is an important thing. The outcomes were not collectively or cumulatively positive. It was even individually. And this was shown also in Odyssey. In Odyssey, in acute coronary syndrome with alirocumab, we can see that there was a reduction in the MACE, which included coronary heart disease, death, non-fatal MI, ischemic stroke, or unstable angina requiring hospitalization. Alirocumab significantly reduced the primary efficacy endpoint, and it showed also an all-cause death reduction, which was a significant thing. So PCSK9 monoclonal antibodies are there to stay because they're not just LDL reducers, potent ones, they are also morbidity and mortality benefits for the patients. But the question says, maybe we should use them for a couple of months, a year, tops, and this is enough. Is the protection for a certain period of time, or this is an extended use? Well, actually, we go back to Fourier. And if you look at the data from Fourier, there was a significant relative risk reduction of 19% over the first 12 months. Is that enough? Should we stop there? Look at the extension beyond 12 months. The significance of reduction of fatal or non-fatal myocardial infarction or stroke is even huge. It's even bigger. It's a 33% relative risk reduction if you extend the usage beyond that. So, as we know, LDL and atherosclerosis is a progressive disease. Don't stop, continue. But what do we mean by consistent reduction or results? This is another important thing, because sometimes we have medications like the SGLT2 inhibitors, dapagliflozin, empagliflozin, very good beneficial results. And we see some outliers like, let's say, ertugliflozin with no benefit. Are the consistency of results in PCSK9 there? Well, actually, if you look at data from Fourier, which are patients with established cardiovascular disease, you can see that definitely, regardless of the type of the established cardiovascular disease, despite the baseline LDL or the intensity of statins or the regimen, whether it was the single dose or the twice a month dose that usually is the one used all over the world. This might be a little bit different from the contrast in Odyssey, which was a great study again, but the main results were shown with those with a higher LDL at baseline above 100. You see those with 80 to 100 or below 80 do not really show that significant reduction in cardiovascular outcomes. This was outlined by Professor Hani Raghi. Multi-vessel disease or single-vessel disease makes sense. If you have multi-vessel disease, the lipid deposition, the LDL deposition is significantly higher. So those with multi-vessel disease definitely benefit more than those with no multi-vessel disease. Not to say that those with no multi-vessel disease do not benefit, they do, but to a lesser extent than those with multi-vessel disease. If it's one vascular bed or multiple vascular beds, that's another good question. And again, this is from Odyssey. And as you can see, the more the vascular bed affection, simple, just like multi-vessel disease, the more the benefit we get with a PCSK9 monoclonal antibody, and it makes sense. How about a recent remote myocardial infarction? And again, Professor Hani Raghi explained that, but let's take a look at a little bit. The more recent the myocardial infarction, the higher the benefit. Not to say if you have a patient with a myocardial infarction 2 years or older, they will not benefit, they will, but to a lesser extent. So this really tells us to go earlier on. Do not wait for the recurrent myocardial infarctions. Do not wait for prolongation of these patients to keep their LDL being deposited in their coronaries or otherwhere. Really start earlier, and this is important. And this is data that was presented by Professor Hani Raghi, so I'm not going to go through it, because we know from Fourier was established cardiovascular disease with 80+% with a previous myocardial infarction, and their average was quite a few years. But here, if you look at the recent myocardial infarction data, which had an average of 4.8 months, the data here was seen in primary and secondary endpoints. And the more recent, the more the benefit. And that's important. How about diabetics and non-diabetics? Actually, both really do this. And there is no really distinctive, prevalence that diabetes is more beneficial than both benefits. And this can be seen also from the subset of diabetic patients in Odyssey. They will both improve as much as each other, maybe diabetics for a little bit higher. But again, that is not to say that diabetics improve more than non-diabetics. Do not, select your patients on their diabetic status. How about plaque regression? And this is important if you have a plaque anywhere. And we know with higher intensity of LDL lowering, whether in high-dose statins or combination therapy, we do have that reduction in plaque atheroma volume. Is there data with PCSK9 inhibitors? And yes, there is. This was the GLAGOV trial. This was evolocumab's data in intravascular ultrasound done. And it had coronary artery disease with luminal stenosis ranging from 20 to 50%. And over the time, those receiving the standard therapy, statins, did not show that atheroma volume to be reduced of significance as compared to evolocumab's addition. Also, the total atheroma volume, you can see the p-value is significantly reduced. And this shows the slowing of regression, and the regressors are much higher in the evolocumab group than those in statins. This will benefit definitely the clinical outcomes. So then we go to another question. I know this question is a little bit tricky. How about PCSK9 monoclonal antibodies versus inclisiran? Will there be a difference? Is there a difference? Well, there are no head-to-head comparisons actually, but we know that PCSK9 monoclonal antibodies reduce the attachment of PCSK9 to the LDL receptor, and thus the LDL receptor recycles itself better and better. So the monoclonal antibodies help LDL reduction. This is in comparison to inclisiran, which is a very innovative way. It's a small interfering double-stranded RNA. It inhibits the production of PCSK9 from the start, and thus it can be given for the first time, a booster dose at 3 months and then 6 months later. Very innovative, actually. But there are no head-to-head comparisons. And this paper is comparing the different LDL reducers. Actually, it was not targeting any single entity by itself. It looked at alirocumab, evolocumab, bempedoic acid, ezetimibe, or inclisiran. and it was just published by Peter Toth last year. It included 48 studies. They took the data from different studies, and this is what it looked at. You can see the monoclonal antibodies are much significantly more potent than inclisiran. So this is important to say. This is, again, not head-to-head, but looking at rather similar patients with similar LDL reductions. But we can take a look that LDL reduction, as Professor Haniraghi just showed us, in EVOPAX reaching the 55, not the 70, is reached in over 90% in EVOPAX. Also, with alirocumab from the Odyssey outcomes, this was achieved in 94.6% of patients. In comparison with Orion's data, which inclisiran has shown this achievement in around 58, 59% or 60%. But all of them are great medications to be used. Also, you can see from Fourier that the reduction of LDL is consistent throughout the period of the study. Maybe a little bit of a slope, not significant, but there is a slope in alirocumab's Odyssey outcomes. Dosing, again, we as physicians just love it when we have a simple dosing regimen. And evolocumab has its 140. The 420 actually has a different mechanism of administration. Alirocumab is not only the 75 or 150, it's also the 300. And this is another question to be asked. When and how, and again, this is a little bit difficult. So these are the medications present in the market all over the world. How soon? We've seen Odyssey was the biggest study on an acute coronary syndrome for PCSK9 that included patients from 1 to 12 months. But also, this EVOPAX study presented by Professor Haniraghi showed that administration of PCSK9 very soon after a myocardial infarction, even within 1 to 2 days, this is safe and very potent for the LDL reaching the goals of 55 or 70. ACS or CCS, chronic coronary syndrome, we know that evolocumab's Fourier trial was mainly on established cardiovascular disease with 80% or more having myocardial infarction. This was important. And Odyssey was 100% ACS patients, STEMI or non-STEMI, but also evolocumab's EVOPAX has done this with the STEMI or non-STEMI inclusion criteria of EVOPAX. So we can see that they take the whole spectrum, especially evolocumab, of established cardiovascular disease, whether in the acute setting or the chronic setting. Finally, we take a look at PCSK9 monoclonal antibodies. They are no head-to-head comparisons. The data here just published a couple of months ago, and I would really suggest look at the first word of this title. It's an indirect comparison. It looked at 30 trials, including around 60,000 patients. Both are very good for reduction of cardiovascular events. Maybe the alirocumab was not showing a cardiovascular death reduction in Odysseys, but it definitely showed, as I've shown, an in all-cause death reduction, which was significant. But the data is consistent in both. And also the site injection reaction was a little bit more increased in alirocumab's arm. Both medications are great. A lot of our patients require them. Look for who really requires them. So definitely our LDL burden is still an unmet need, and we still have to improve our statin usage and ezetimibe dosing. This is an important thing because we're not using these medications up to their utmost. Monoclonal antibodies have been shown to reduce LDL and cardiovascular events, not just LDL. And this is quite important. And the difference between the different molecules are very subtle because there are no head-to-head comparisons, and there will never be. But always look not only to the familial hypercholesterolemia, look also to the multivessel disease, the recent myocardial infarctions, the polyvascular disease, those at high risk of recurrent events. These are the patients that will probably benefit most from these medications. And thank you.
اللي المفروض ياخدوا بيسكنا هو طبعا any patient who did not reach the goal for his risk category هنضطر، خصوصا لو كان بعيد شويه عن الرقم، هنضطر لازم هياخد بيسكيناين. بس احنا علشان الكوست بنحاول ان احنا ننقي من الترايلز العيانين اللي خدوا اللي ليهم اكبر استفاده، سواء الاكيوت كورونري سندروم، سواء اللي عنده مالتي فيسل ديزيز، سواء اللي ريسنت مايوكارديال انفاركشن، او سواء اللي فيري هاي ريسك بيشنت ولسه ال دي ال فوق 100 مثلا، رغم ان كومباينيشن ليبيد انتنسيف ليبيد لورنج ثيرابي. فاعتقد ان احنا كده بقى عندنا من المحاضرات المختلفه دي ليست اوف انديكيشن في دماغنا. دكتور هاني راجي عايز يقول حاجه
بعد ما حضرتك تتخلص؟
لا انا خلاص اوكي، انا خلاص.
انا حضرتك عندي ملحوظه، هو انا عندي كونسيرن على، يعني ما عنديش اي مشكله ان في العيان اللي محتاج PCSK9 ومش قادرين نوصله له عشان الكوست، بس I have a real concern for the patient who needs a PCSK9 and who either has no cost issue or their insurance has no cost issue, who are not receiving the drug because we forget or because we think is expensive. فهو what my recommendation, and I would recommend two things وحطيت ده على الشات دلوقتي. اول حاجه ان احنا we need to do an PCSK9 Egyptian registry.
Great idea.
كلنا عم بنوصفه والعيانين طايره في الجو، الوحاد اللي عندهم الداتا بتاعتها معمل برج ومعمل مختبر، حاجه عيب يعني. ف we have to have a registry. The other thing is we have to have a sentence in every patient's sheet اللي هي ال health records بتاعته. Or is this patient indicated for PCSK9 green orange or علامه كده عشان نعرف ان هو العيان اللي indicated سواء بياخد او ما بياخدش، وعشان لو كان ما بياخدش لان احنا نسينا او في اي سبب تاني محدش وعى العيان وهو يقدر. يعني I'm amazed at the number of patients اللي انا برمي كلمه كده، لان خد بالك ان البي سي اس كي 9 اللي هو الفيري ايرلي افتر اي سي اس ده احنا وي هاف نو داتا العيان ده هيكمل قد ايه على فكره. يعني اتس بوسيبل، وي دونت نو، اتس بوسيبل ان هو لو ما كانش معاه فلوس بعد سنه هيكون خد استفاده جامه في الفتره دي، ونقدر يعني وي دونت نو. اوكي وي دونت نو. الترايلز دي ما استمرتش مدى الحياه، nobody said ان هو هيستمر مدى الحياه. انما would 6 months of PCSK9 after a stormy acute coronary syndrome, and then if the patient has to stop because they have no money and they continue on high dose statin and estimate, would it lead to a benefit? Maybe. Actually, what we know, it would definitely lead to a benefit, but we don't know إذا كان البنفيت ده هيستمر بعد ما نبطل ولا لا. إنما there will be a mortality benefit, a stroke benefit, وطبعا احنا عارفين إن الحاجات الاسكيميك حاجات دي أوقات بتحصل ورا بعض كتير في العيانين اللي هم عندهم ف you may be able to bridge the patient through it. I don't know. أنا بتكلم على ظروف مصر الاقتصادية. ففكرة إن في أعداد هائلة من العيانين و are both indicated وفي طريقه انهم ياخدوه سواء عن طريق شغلهم او تامينهم او اموالهم الخاصه وما بياخدوش، فده عيبه في حقنا. It's my personal opinion.
عندي كومنت يا دكتور اشرف بعد كده خالص in 2 words. يعني الف شكر يا دكتور احمد.
Thank you.
في استادي شغاله حاليا اسمها الهايجنز ستادي. هايجنز ستادي دي معموله على الفلوكوماب على البلاك فينوتايبنج with optical coherence tomography to study التشينجز اللي بتحصل على البلاك ستابيليتي اللي موجوده، عكس الجلاكوف كانت الريجريشن اوف اثيروما فوليوم. فالجلاكوف نجحت في الريجريشن. الثانيه دي كمان هتورينا ازاي الفلوكوماب ده او البي سي 9 ميكرون انتي بودي فلوكوماب والتشينج الفينوتايب بتاع البلاكس عشان الرابشر اللي بيحصل منها والاستابيليتي. فاعتقد ان دي هتبقى ايرا كمان متقدمه في ان احنا نحكم على الادويه دي وازاي ان احنا نكمل بيها. ولازم احنا برضو برجع بقول لدكتور اشرف، احنا كاوثوريتيز ساينتفك اوثوريتيز وي شود بوت ان امباكت على الهيلث سيستم عندنا بالكونسنسس اللي موجود بالإديوكيشن اللي موجود عشان نوسع استخدام الBCK9 انهبيتورز اللي موجوده، لان جاي الانكلسران وجاي بعده حاجات كتيره جدا، واحنا ولسه الناس ما بتكتبش هاي انت سيستم. فاحنا عايزين يبقى في عندنا امباكت.
والله يعني عايز تعلق يا دكتور احمد؟ اتفضل.
Very good points, Professor Atif. يعني just quick comment. This is what we really see from Amgen. كنت بوري how definitely Amgen really studied everything from plaque regression to acute coronary syndromes to late coronary syndromes. And what you're saying about the possible pleiotropic effect of PCSK9 is incredibly important, and your lecture about it was actually super. Thank you so much.
Thank you, Dr.
خلوني let me finish this today's session بالايديا بتاعت هاني راجي اللي هو ريجستري على البيسكي 9 انهبيتور في مصر واستخدامها. الخطوه الاولى في هذه الريجستري ان احنا نعمل الكترونيك CRF كيس ريبورت فورم، ايه الايتمز اللي احنا عايزين نجمعها لكل عيان. ويمكن في تجربتنا مع الفاميليا هايبركوليستريمي ريسيرش فورم اللي عملناه وانتهى بداتا جميله جدا، فيمكن احنا مع امجن نقعد معاهم بزنس ميتنج نشوف ازاي نعمل بيسكي 9 ريسيرش فورم. وهذا البيسكي 9 ريسيرش فورم يبقى دوره مش بس الاويرنس ونشر الوعي باستخدام البيسكي 9 انهبيتور، وانما واحده من الاوبجكتيف المهمه بتاعته ان احنا نجمع الداتا تايب اوف ذا بيشنت، الفينوتايب بتاعهم، الليبيد بروفايل، مين اللي بيكتب البيسكي 9 انهبيتور في مصر، البيز لاين ليبيد بروفايل بتاعهم ايه، الريسك كاتيجوري بتاعهم ايه، النتائج بتاعتهم بيستمروا قد ايه على العلاج. فlet me finish with this, and actually I enjoyed all the presentations, and I would like to thank the faculty, the great faculty اللي معانا النهارده. I would like to thank Amgen and thank ICOM for their technical support, and see you in next Cardio Risk Waves, inshallah.
Thank you.
Thank you.